Hello and welcome to the ISLC Lung Cancer News Multidisciplinary Forum, where we'll be talking about molecular challenges. I'm excited that we have the molecular challenge himself here as one of our faculty. Bill, would you like to introduce yourself?
Hello, everyone. My name is Bill Brand. I am the mayor of Redondo Beach, California.
And his primary oncologist, Dr. Natale, would you like to introduce yourself?
Hi, Ross. Bill, glad to be with you for this forum.
So Ron Natale is the director of the Lung Cancer Clinical Research Program at Cedars-Sinai's Medical Center in Los Angeles. And then I'm the director of thoracic oncology at the University of Colorado Cancer Center. Here are our disclosures. So what we're going to talk about is some details of Bill's case, how he first presented and how he ended up with Dr. Natale, and then how, together with some of the patient advocacy organizations, Bill ended up reaching out to me and how we got a remote second opinion, and then how we all worked together through some of the bumps in the road that happened and then where we are today. So Bill, let's start with your case. This goes back to June 2019.
Yeah.
61 years old at the time, fit, male, never smoker. And, talk me through what happened. I've got written down you're on a flight to Mexico, but what really happened?
Well, yeah, I was on a flight to Mexico by myself. I was going to go surfing for a few days in a conference. The new president of Mexico had invited me to some conference in Cabo, so I need to go to that. And I went a couple of days early so I could go surfing. So I'm flying down. It's a beautiful flight. Everything's fine. Talking to this nice couple next to me from Snow Valley, I think, in California. Anyway, you kind of doze off on a plane, and you wake up. And I woke up, and the nice couple was gone, and there was another lady sitting next to me with an oxygen tank and a mask. And I looked at her, and I said, "Who are you? Where'd you come from?" Excuse me, I have the hiccups. You might hear me there. And she goes, "Well, I'm so-and-so, and I'm a nurse practitioner, and you had a seizure, and I came to be with you." I was like, "What are you talking about?" And I said, "How long was I out?" She said, "About an hour." And it had felt like 5 minutes. He doze off on a plane. And I didn't really, and I was dazed, like, I didn't know what this is going on here. And then I felt my tongue. I'd bitten my tongue during the seizure, and I could taste the blood. And that's when I realized, wow, something's really happened here. And plane lands 10 minutes later in Mexico, by myself. And, they come and get me in the wheelchair or wheel me out, give me a taxi, send me to the hospital, which immediately sends me to a clinic. I go in there, they're very nice. Kept me overnight for observation, put me on some sort of steroids. I woke up the next morning. And they said, "Look, Mr. Brand, we have no idea what happened. This has never happened to you. You can go to your conference. Don't go in the water. Like, don't even draw a bath. Okay. If you had been in the water with this seizure, you would have drowned." So I went to my conference. I went home, and my back was sore because I guess during that seizure I tweaked it all up, and my tongue was, Anyway, I went home, told my general practitioner. He was very, very concerned. He immediately ordered a brain MRI. The afternoon of the morning of the brain MRI, he called me at home and said, "Bill, you need to go to the hospital right now. They found a mass in your brain, and don't drive yourself, get an Uber, and they're waiting for you at the emergency room." I was just stunned by the whole thing. I had kind of even forgotten I'd had the MRI that morning. Anyway, so I go there, and there's the brain surgeons there and the emergency room doctor, and they're showing me the scan that you're seeing there, right there, pointing to it, going, "Well, Mr. Brand, we're really sorry, but that's got to come out." And I'm like, "What are you guys talking about, brain surgery right now?" And they said, "Well, maybe tonight, probably not till tomorrow morning." And so I'm just freaking out the whole thing. And my wife's in China, and she calls in the middle of all this and finds out. And got to rush home from China. She's freaking out. Anyway, so they take me up to the room. They do a full body scan, and I'm up in this hospital room, and people are starting to come. And anyway, the doctors come in that night at Little Company Mary Hospital in Torrance and say, "Well, we got good news and bad news. Good news is there isn't going to be any brain surgery, but the bad news is you have lung cancer, which has spread to your brain, which is what caused the seizure on the airplane." So yeah, we got a lot to do. We got a lot of tests to run. We got to figure out where else it might be, and. So got up the next morning, all these tests, and they, all these doctors are coming in. I must have seen 5 doctors, a neuroradiologist, oncologists, no one I ever met before in my life. The oncologist that had been assigned to me was a Dr. Rue, very nice. Radiation therapist was Dr. Karen Sokoloff, who really was really kind of a guide for me. Right then, I go, okay, I got to listen to this woman. For some reason, after all the people I've been talking to, it really zeroed in on what she had to say. So anyway, I went from there and, saw Dr. Rue. They did a test, on a genetic test on my, type of cancer, and probably took, 2 weeks before I was in Dr. Rue's office, telling me that I had hit the jackpot and that I had been identified as a ROS1 positive patient, and that they had a targeted drug that they were going to put me on instead of, chemo and all that, or maybe with chemo, but she just wanted to do the what was at the time they called Xalkori, and which is crizotinib. So I said, okay, I'm 2 weeks into this. I really don't know what's going on. And, I live in LA, and there's a lot of options for second opinions. And, Dr. Rue was great, but it was only one doctor. And so I had been told by a friend that they had a friend who had lung cancer, had been seeing Dr. Natale at Cedars for quite some time, and was very pleased. And so I was looking for a second opinion. So I contacted Dr. Natale and got an appointment with Dr. Natale.
Well, let's pause there for a second, Bill. So in terms of the medical background to what you're saying, we saw the MRI of the brain with the deposit in the left side of your brain. Here we can see the CT scan showing a mass at the top of your left lung. And then in addition on that CT scan, they found a deposit in the middle of your thoracic spine. They didn't do a PET scan, but they did a bone scan, and that's the kind of blurry looking skeleton in the bottom left-hand corner here. And there were multiple other deposits in the bones. As you said, they biopsied something. So they biopsied that thing at the top of the left lung, and it was indeed a non-small cell lung cancer. So TTF1 positivity is one of the features of non-small cell lung cancer, particularly adenocarcinoma. It's a cancer that comes from glandular tissue. And then they sent off some initial molecular testing. And this is going to become key in terms of our discussion. But the molecular testing they sent off was to look for mutations in something called BRAF and EGFR, both of which were normal. And then the jackpot that you're referring to is they did a FISH test, fluorescent in situ hybridization, for something called ROS1. And the cut point for positivity is about 15%, and they reported 74% of cells showing positivity. And then they also did that test for immunotherapy, PD-L1, which was about 8%, which is pretty low. So let's move to Dr. Natale. So you now go see Dr. Natale. So Ron, what was it like?
Well, I was impressed. He was in terrific shape. He was feeling pretty good at that time. Steroids reduced the small amount of peritumoral edema, so I wasn't concerned about seizures at that point. He was having some mid-upper back pain from the T6 metastasis, and we did obtain MRI scans. I think those were actually done at his community hospital that were reviewed and confirmed metastases in several vertebral bodies. I talked to the radiation oncologist that had seen him at Little Company of Mary, his community hospital. And I know her quite well. She's an outstanding radiation oncologist. And we discussed the typical dilemma of a solitary metastasis. Should it be treated with excisional surgery, followed by radiation to the tumor bed, or can we treat it just with stereotactic radiosurgery? And it seemed reasonable given the size of this tumor. It was small, as you saw in the MRI scan, to treat it with just stereotactic radiation therapy, and to begin him on crizotinib, standard drug that's fairly effective in patients with ROS1 altered non-small cell lung cancer. The penetrance of crizotinib into past the blood-brain barrier is debated. Does not have the CNS penetrance of some other tyrosine kinase inhibitors, but it probably has some. But in this case, since we had a solitary brain lesion that we were going to treat definitively with SRS, we were confident that crizotinib would be a potentially effective treatment for his systemic disease. We did do a baseline CT scan of chest, abdomen, and pelvis to define the left upper lobe primary tumor mass, reconfirmed some of the skeletal lesions that could also be seen on CT scan, and proceeded with treatment. So he received standard dose crizotinib, 250 milligrams twice a day. We obtained a follow-up CT scan, PET CT in this case, 6 weeks after the start of treatment. And unfortunately, that demonstrated some slight increase in the size of the left upper lobe mass. He was having increasing back pain despite the start of radiation therapy. Actually, we may have deferred the radiation therapy at that point and actually started it with this scan that demonstrated further destruction of T6 and possibly several other bony sites. There was some discordance in the metastases noted on PET scan versus bone scan and MRI scans. The PET scan underrepresented the number of metastases, which is a little bit of an unusual clinical observation. But by that time, Mr. Brand had joined the ROS1 patient advocacy group. And
well,
I'll take it there.
Yeah, let's pause there just for a second. So, so single lesion in the brain treated with stereotactic radiosurgery, started on crizotinib because of this ROS1 result. And you've tipped your hand a little bit that the first scan didn't show the amazing response that we were hoping for. But let's bring Bill back in. So at what point did you even hear about the ROS1 patient advocacy group, and how did you address that?
I believe Dr. Rue first told me there was a ROS1 advocacy group on Facebook. And so I immediately went looking for that. And of course, there it was. And I signed up. I'm recently diagnosed as ROS1. And then it opened me up to a lot of people discussing ROS1 and what it meant and what the side effects of Xalkori were and treatments for that. And so it was a great way to connect socially with people who had similar problems. Same for my wife. She was able to sign up and see what people were talking about. It was quite helpful and encouraging because a lot of people were having a positive response from this. One thing, just to clear up some timeline, I'll tell you, I had a decision to make. I decided to switch to Dr. Natale because after my first visit, I just had a better rapport right away and I was more comfortable with his ideas. And one of the things he recommended was not just to go on the Xalkori at that time, but also to start chemo. What ended up being Alimta, carboplatin, and Keytruda at the same time as Xalkori. And I thought, and this is a decision I had made, well, why would I do that if you've got this targeted drug? And I remember Dr. Natale telling me, well, Bill, it's just my experience that people who hit this early hard with as much as they can do the best. But I was like, well, but we've got this targeted drug. Why don't we try that before I consider, these other, much more impactful side effect stuff and thing. And so I wish I would have listened to Dr. Natale in the very beginning, because as a result of finding out that I had been misdiagnosed with ROS1, I went without treatment for another 3 months.
Oh, you're tipping your hand too.
Well, and so I never really did any radiation treatment on my back till September. And I ended up not starting any real effective treatment till September as a result.
Well,
I wish I would have done what Dr. Natale said at the beginning.
Well, yes, I often wish I'd listened to Ron Natale on many occasions. So let's touch base, because I think this is where I come in. So you contact the ROS1ers, and then how did you hear about second opinions or remote second opinions?
On the ROS1 Facebook site, and I saw an interview with you, Dr. Camich, and you're obviously highly respected by everybody. And I used to be an engineer, and I'm, you know, a mayor, and I just always looking for more opinions and more information. I thought, well, why don't I do a remote consult with Dr. Camich? And so that's how I found it.
So what? So I can take it from this point. So what happened was that you reached out to me. I think you sent me an email. I even think one of the ROS1 had sort of done a sort of email introduction to me. And we set up a phone call, which was done before you had your first scan on treatment. So it was done in August. You were still on crizotinib, and you know, I know Dr. Natale and have done for many years, and so what I communicated to you, with your permission, I then also emailed to Ron afterwards, and what we said was, you know, absolutely, Plan A is a great one. You know, you've got this positive FISH result, and you know, the chance of the crizotinib getting into the brain is not very good, but outside of the brain, you're expecting that lung mass to shrink, and the stuff in the bones sometimes can become more visible because it actually lays down more bone. That's called sclerosis. So I just kind of warned you that if they suddenly say they can see new things in the bone, doesn't necessarily mean progression. And a bit like Dr. Natale's idea of adding in chemotherapy to hit it hard, I kind of gave a similar but different approach, was that for some people, you know, you take the treatment to the maximum response, and then you hit it hard in a different way by consolidating the disease with radiotherapy when it's in a relatively small sites of disease. A few other things I kind of threw out because we were sort of talking about the future, and you were always asking me, you know, then what? And I threw out the idea that because the drug doesn't get into the brain very much, you know, you could have more radiotherapy in the brain if more lesions turned up. We also pointed out that there were some other ROS1 inhibitors which have more penetration into the brain, including one called entrectinib, which is licensed, and lorlatinib, which is not licensed, but you can also use. And then for reasons, and I don't know why I wrote this at the time, but this is a direct quote from the letter that I sent you. For some reason, the fact that the diagnostic for ROS1 that you had was FISH, which used to be the original diagnostic, was a little old-fashioned. I kind of put in a little caveat that said if you had rapid progression in the body, I would just double check that diagnostic. And the reason is, just occasionally, some of these other diagnostics that we used to use, immunohistochemistry or FISH, can give you both false positives and false negatives. So for whatever reason that turned out to be important in retrospect, was I just sort of threw that out that said, if something funky happens, we should recheck that. So let's bring in all of us together. So some people worry that a second opinion, admittedly, Dr. Natale was your initial second opinion, but every time you add a second opinion, you're adding more to the mix. And also, you know, doctors have egos, and how do we react to it? So Bill, I emailed Dr. Natale straight away, but Bill, how did you deal with the idea of the remote second opinion? Did you tell Dr. Natale you're going to have it? Did you kind of surprise him after the event? And Ron, what was it like?
I don't really remember exactly how it went. I was just getting another opinion. It was over the phone, so it wasn't hard. I think I told Dr. Natale. He didn't seem to care. He knew you. You guys knew each other, so that helped. I don't remember it being a big issue. You pretty much agreed with Dr. Natale. I can't think on any area you disagreed. And then what really changed everything was when I got the Garden 360. I mean, when I came in to look at the PET scan with Dr. Natale, he was very concerned. Immediately ordered a Garden 360 blood test, and then that came back, and he called me, said, "I'm really sorry, Mr. Brand, but you've been misdiagnosed. You are not ROS1."
Well, let's get to that in 2 seconds. Ron, what was it like? Can you remember, you know, some other random guy being involved with your patient? What was that like?
Oh, I never have a problem with that, especially for a patient like Bill. He's you know, well-educated, you know, sophisticated person. He's a strong advocate for his own health and well-being. He consulted with a lot of different oncologists in Southern California. I don't know the exact sequence, but I think City of Hope and probably a few other places as well. You and I have shared several patients, and your evaluations are always very comprehensive and thorough and thoughtful. We may have some small disagreements on some minor issues of management, but I think you and I have largely followed the science with respect to treating patients with lung cancer. And this particular kind of lung cancer is something that community oncologists rarely see, if ever, because it is so uncommon. And so I think you see, I'm sure, a handful a year as I do. And so having expertise of another expert, I always welcome. My initial plan was to confirm the response to crizotinib and then to consider adding concurrent chemotherapy. I think you did not agree with that strategy initially, but that plan A was put aside by the fact that crizotinib did not work. And I thought the next best treatment was lorlatinib, which was one of your recommendations as well.
Yeah, let's move to the scan. Do you want to talk this through in terms of what was happening? So you get that first scan in August after 6 weeks or so on crizotinib.
Yeah, so, you know, for all of these oncogenically driven cancers, whether they're EGFR or ALK or ROS1, BRAF, the TKIs, when they work quite rapidly. And you certainly will see significant tumor regression if there's tumor sensitivity by week 6. Delayed responses are rare with TKIs. Patients may not have achieved the maximum response. In fact, the maximum radiographic response with drugs, for example, that target mutated EGFR is between week 6 and week 12. But if the patient hasn't had tumor regression by week 6, and in this case, there was some disease progression and worsening of bony metastases, I was comfortable in abandoning crizotinib and moving on to something else. I was also concerned regarding whether or not this was truly a ROS1 altered lung cancer, and so ordered 2 additional tests, circulating DNA test through Guardant Health. It has a pretty good platform, and a repeat tissue molecular test by Foundation One to look for an oncogenic target.
Well, here's the Foundation report. So the Guardant report. This is the blood-based testing. So do you want to talk us through this?
Yeah, so here is the Guardant result that shows a little over 18% of the circulating DNA having an ERB2 insertion mutation in exon 20. So completely different than the ROS1 and a TP53 slice mutation.
Yeah, and no ROS1 at all.
I'm sorry?
And no ROS1 at all in the blood test.
No ROS1 at all. Now, you know, that will bring up additional points for discussion. I don't know if you want to discuss that at this point, but it certainly was concerning and convinced me that lorlatinib was likely to be a failure as well. So I had a short leash on lorlatinib since I had a patient in whom I'd already lost 6 weeks of treatment if this was indeed not a ROS1 altered lung cancer, and that I had now embarked on lorlatinib based on that original FISH test. I usually have a lot of confidence in FISH tests. I think they're, you know, more specific usually than sequencing. Sequencing can miss some of these alterations and mutations. But I had a short leash, and in fact, once there was confirmation of slight further disease progression, while I was awaiting the results from Foundation One on the tissue to confirm a suspected now ERB2 mutation, for which, as you know, we've not had, as of the time that we're talking about here, fall of 2019, not a lot of highly effective drugs. I decided to default to treatment with platinum pemetrexed. And now that my patient was no longer on a TKI, I thought it was safe to proceed with pembrolizumab as well. Keep in mind, his original tumor had about 8% PD-L1 expression.
Yeah. Okay. So, so Bill, how did you address this? You know, you'd become at that point in time a prominent member of the ROS1 group because you're a go-getter, and then suddenly it's like, hey, you're waving the wrong flag. So, how did you deal with that?
Well, you know, I just left the ROS1 group and went to the exon 20 with the, you know, exon 20 insertion group. And it wasn't nearly as active as the ROS1 group, but there were people on there and talking about it. And yeah, it's all, you know, you just get overwhelmed with information and changes in conditions. And now I'm in back pain, and you know, I really, you know, wasn't in the big mode yet of getting onto Facebook and talking to yet another group. I was dealing with, you know, the new treatments, and the chemo and the radiation, and yeah. So it was only after I kind of got through that I started paying more attention to the exon 20 group, which became very, very helpful. And I learn things all the time, just reading people's experiences. So I find the ability to talk to other people in the same situation extremely helpful and comforting. But in the final analysis, I was just doing what Dr. Natale told me to do, whenever that was, as well as Dr. Sokolov.
Okay. So I think this then led to, so I think my understanding is you actually responded to that chemo immunotherapy initially, and the PET scans
Quite well.
Yeah, the PET scans here are a little misleading because the one on the left is your before you start on the chemotherapy, and we couldn't find the one in the middle, but the one in the middle actually had a very dramatic response, which I couldn't find. But the one on the right here is actually after you had started to progress, so it went down a lot, and the one on the right, even though it looks better than the one on the left, is actually the beginning of progression. So that, I mean, how long were you on the chemotherapy for?
Well, I started September, October, November, December, January, February, March, April, May, June. 10 months. June was my last treatment with that. Yeah, I had 4 cycles of carboplatin, and then I just went to, I just another trade name to Limton, Keytruda, and then I was on that for the remaining time. And it worked quite well. I mean, I remember Dr. Natale saying at one point, your tumor was down about 90%.
Yeah. So you had a really nice response, and then, you know, come the summer of 2020, things started to get worse. And I think the other thing that happened was that you had a repeat brain scan, and the area in the left temporal lobe that we saw, you know, that had sort of tipped you over the edge on that flight to Mexico, had started to get a little bit bigger. And I think at that point you called me back, and we had a repeat remote second opinion. And so if I kind of summarize what we talked about at that point in time, you know, you were at a decision point. My first thing was that thing in the brain that was getting a little bigger was probably not progression. Stereotactic radiosurgery is actually remarkably good at destroying an area, and it's probably something called radiation necrosis. You know, that little rim of normal brain cells around it can die off. And because brain cells don't turn over very often, they sometimes take a little while before they know they're dead. And then when they die off, there's some swelling around it. So I think that was my first thought about the brain. But then, having initially had a conversation with you about ROS1 rearranged lung cancers, you know, I had to pivot too. And we talked about the significance of these HER2 mutations, of which you have the most common one. So they're called insertions. So they add in a little bit of DNA, often into a part of the gene called exon 20. So they're called HER2 exon 20 insertions. And that extra little bit of DNA introduces some additional amino acids, of which the most common is 4 additional amino acids, which go by the abbreviations YVMA, and that's what you had. Mm-hmm. So at that point in time, as Dr. Natale mentioned, there's no licensed drug in lung cancer for treating HER2 mutant disease, but there were treatments in trials, and they fell into 2 broad categories, those which are tyrosine kinase inhibitors, so pills, or antibody drug conjugates. So the first pill that was kind of proof of principle was a drug called crizotinib, but unfortunately that was very toxic. Another drug was called tarloxitinib, which is intravenous rather than the pill and is weekly, so a rather inconvenient schedule. And so we talked about some of the newer pills coming out. One is called TAK-788 or mobocertinib. There we knew it certainly had about a response rate in about the 40%-ish range, although it wasn't very good at getting into the brain. The problem is you were kind of in the donut hole of clinical trials. The trials had finished accruing, but they hadn't got the drug licensed yet, or they hadn't got a compassionate access or expanded access program. So you're kind of stuck in the middle. I did reach out to the company to see when they were going to get an expanded access program, but that was still a little way off. But I knew that there were other drugs. There's one made by a company called Black Diamond, and then the other is made by a company called Dizal that were an option. The other thing we mentioned is these antibody drug conjugates. And DS8201, which goes by the trade name of Enhertu, actually had recently been licensed in breast cancer. But we'd seen data in HER2 mutant lung cancer where it had something like a 62% response rate. Again, big molecule, unlikely to get into the brain, but that was another option. So we said, go seek out a HER2 tyrosine kinase inhibitor in a trial, or can we get access to Enhertu because it's sitting in the pharmacy for breast cancer if your insurance will cover it. Mm-hmm. And at the end of the letter, I said I was going to check with the company about expanded access. I helped you find out where some of these clinical trials were. And then regarding that thing in the brain, I just fed back that there's a particular kind of MRI called arterial spin labeling, or ASL, which can sometimes help determine the difference between radiation necrosis or progression. And I just sort of said you should keep an eye on it. And I passed all that back to Dr. Natale. But why don't we move? So that was in the summer of 2020. So why don't we talk through what happened? So, either Dr. Natale or Bill, do you want to talk us through what happened after you progressed on the chemo in the summer?
Well, I'll start it off just, so we figured out that it had stopped working. It was clinical trial time, and there were several out there. I remember doing another remote consult with you just to get yet another opinion, and from someone like you, it'd be fantastic, and you guys knew each other. But we decided probably my best option was DZD 9008 or BDTX. You had mentioned maybe going in HER2 in the interim, but it looked like I was going to get on one of those trials quick enough. And the reason I chose DZD is because Dr. Natale figured out that BDTX would not exclude me having been on another targeted drug. Whereas if I went on BDTX, I would not be eligible for DZD if it didn't work. Wow. So,
okay. Oh, so it gave you maximum lines of therapy.
Exactly. So it opened up my.
And BDTX was still in the dose escalation part of its phase 1 development, and not at the doses that are currently being studied today. So I think the decision to go with DZD 9008 before BDTX or other available agents was a good option. There was emerging data on Enhertu at that time. There was an abstract that had been presented that gave rise to now a national phase 2 trial. And the phase 1 abstract, had a 72% response rate. And, follow-up studies have shown it's in the range of 60 to 70%, which really comes as a bit of a surprise to me, Ross. I don't know your perspective, but for these oncogenically targeted lung cancers, the TKIs usually work way better than the antibodies.
Yeah. So I think there's something, as a small aside, there's something unique here. So an antibody drug conjugate is just a toxin attached to an antibody. And so here, with this very high response rate, it probably tells you one of two things. So one is the cancer, because it's addicted to that oncogene, can't suddenly just stop making it and become resistant in that way. Whereas for other antibody drug conjugates, if it's just a marker on the surface of the cell, one mechanism of resistance is it just sheds it. The other is, we know that there is a difference in chemosensitivity between some of these different oncogene addicted subtypes, and it may be that the toxin that they have in HER2, which is a topoisomerase 1 inhibitor, for whatever reason is particularly potent in HER2 mutant lung cancer. So they kind of luckily had a double whammy there.
So, the DZD 9008 didn't work, unfortunately. And so then the issue was, do we jump on the BDTX trial that now is getting to dose levels or responses are beginning to be observed? Or do we go within HER2 where the data are accumulating and a response rate of 60 to 70%, you know, I must say is pretty impressive, targeting an oncogenic driver against which we have historically had very little success until now.
And so, I mean, were you worried at all? Because we've had one false alarm with the ROS1, and now we have the HER2 mutation and not, I mean, I think it's debatable as to whether there was any benefit from the Dizal drug at all. I think when I looked at Bill's tumor markers the other day, there was a tiny dip, but it was very short-lived.
Yeah, well, this remains very confusing. I spent some time talking with the some of the major players at the NeoGenomics. You know, they're a pretty good group. They perform over 100 FISH tests per day. They have an enormous volume, and they're very confident in their report of that 74% of cells on their FISH test did not express one of the two markers. I think in this case it was loss of the green marker that was at the 5' location, the non-TKI location, which they interpret as a positive, positive test. Now, given the lack of response to crizotinib and lorlatinib, I suspect that, well, there's three possibilities. Either that this ROS1 abnormality is non-oncogenic, positive test, but it ends up being a false positive. Okay. And proving false positives, of course, is extremely difficult in this area of molecular diagnostics. The second possibility is that there is an oncogenic ROS1 that coexists with an oncogenic ERB2 mutation. And that's not ever been reported before. And having two oncogenic drivers, as you know, Ross, is quite rare. And you know, it raises the possibility to have a successful therapeutic outcome. Do we need to target both oncogenic drivers? And you know, the third possibility is that this was a lab error of some sort.
Yeah, I wondered about that. And I
enormous experience with FISH testing.
I mean, I agree with your possibilities. I think the fact that when we did the next generation sequencing, we didn't see a gene rearrangement in either the blood or on Foundation Medicine in the tissue, that somehow the FISH test wasn't predicting a functional ROS1 gene rearrangement. And that's why I think it's probably not that there's two drivers present. Although so far that would actually fit with the clinical data we have in the sense that, you know,
a false positive, right?
Yeah. I mean, one of the things I remember when I was trying to explain it to Bill is I'd wondered whether the ROS1 had somehow, you know, created the gene rearrangement and yet somehow messed it up along the way. So it was trying to, I think the analogy I was doing is like you had the plans to build a car, but somehow the engine wasn't in there at the end of the day, so it could never get out of the garage. And so the cancer says, well, that's not going to be driving my cancer. So you had to have another oncogene, and that's where the HER2 came in. So I think it was a kind of failure to launch for the ROS1 as an oncogene. But until we start to see a response with a HER2-directed therapy, that's all hypothesis.
Well, we're going to repeat the FISH test using a different probe than the one used in NeoGenomics.
Okay.
To see if we confirm that 74% of the cells are missing one of the segments. And if we confirm that with our FISH test, we may try to get sufficient tissue from the original biopsy a small fragment that we have here to try to do what has been described to me as step sequencing, to try to understand what this ROS1 rearrangement is, to try to get further data as to whether or not it actually could or could not be an oncogenic driver. I'm not sure that this effort will help in the management of my patient, but it might. But it certainly will help us, I think, in understanding an important aspect of molecular diagnostics, a problem that is not common, but as we move forward, we will encounter again.
Yeah, the other thing you can do is there is a ROS1 IHC test, because at the end of the day, you can have all of the genetic changes, but if it doesn't result in a protein being expressed, it can't function as an oncogene. So that's another thing to think about doing. So one of the things to touch on, and I know the Exon 20 group was very interested, is let's do a thought experiment. Let's imagine we put Bill on Enhertu, and I think you started yesterday. So if you respond, that's awesome, and that would be supportive, but not proof positive that HER2 is actually driving your cancer, because of course you can just deliver a toxin and the cancer can respond for other reasons. But let's imagine the worst case scenario. Let's imagine we get the repeat scan in 6 weeks and it's not working. Where are we going to go there?
Wow, good question. Bill, how'd your treatment go yesterday?
Oh, it was easy. It was quite easy. Wonderful staff. People were fantastic. And the only side effect I've had so far is staying up late from, I guess they gave me some steroids. So otherwise I feel fine.
Well, Ross, I agree with you. If we do get an objective response within HER2, which is obviously my greatest hope, that would raise the issue, provide evidence that the ROS1 abnormality is non-oncogenic. That, in other words, we got a false positive FISH test.
Yeah.
And I think maybe it's not conclusive, of course, but it's strongly suggestive. And maybe the first false positive ROS1 FISH test that's been observed. If we don't get a response, we're in big trouble. Depending on what our FISH test and step sequencing shows with ROS1, I might be, 2 months from now in a position that if Enhertu does not produce a response, of coming back to you, Ross, and asking, what do you think about adding a ROS1 TKI to Enhertu and hit 2 co-driver oncogenic mutations?
Yeah, I mean, I think one of the key things is, and this is true, and it's kind of like the lessons we've learned along this way, is if the molecular testing says X is supposed to happen, and it doesn't, it's not always that you're on the wrong drug in the simplistic sense, and you need another drug directed against the same target. You have to go back to basics and say, hey, maybe my target is misleading me. And so I would probably push for another rebiopsy and reanalysis, like you say, using different methodology. I might even, depending on how feasible it is, there are some labs that can even try and grow the cells from a biopsy, and then we could actually sort of poke it around and see what it was actually sensitive to. So I think we would definitely go back to basics if Enhertu was a bust. There's one other thing I'd throw out there. So
I would assume, let me just interrupt.
Yeah,
I would have to assume that won't Enhertu stop working at some point?
Yeah, but there's a difference between you go on and it stops working in 18 months' time, and we kind of have proof of principle that this worked, versus you blow through it. And the reason that matters is if you blow through it, before we start saying, oh, we're going to go on the black diamond drug or something, we have to question whether the label we've stuck on you is right.
Yeah, I agree. I think 8 weeks from now, Bill, if we don't see significant tumor regression within HER2, I think I would favor getting another biopsy of the tumor with complete characterization, as complete as we can perform now, before embarking on a new line of treatment.
Okay.
And then some of the other things that Ron and I had just exchanged some emails the other day, and Bill, we chatted about on our phone call the other day, is, even if we don't know what the driver is, if this doesn't work, we could still think outside the box, because one of the things is, here we are a year and a half from when you were first diagnosed. And sure, you had one spot in the brain that got zapped, and you had some stuff in the bones which have been zapped for pain control. But most of your disease is really just this blob at the top of your lung and some lymph nodes. And so could we think outside the box and be aggressive about radiotherapy, even if we don't know what the driver is?
You mean more radiation, like on the tumor itself?
Yeah, I mean, can we talked about the difference between palliative doses and ablative doses. Could we ablate, the mothership in the lungs and the lymph nodes? Ron, I don't know. I mean, you're up for giving chemotherapy when I'm not with a TKI. Do you think I'm crazy with suggesting radiation in this setting?
Well, a desperate.
You can say yes. I won't be offended.
Yeah, desperate situation will certainly call for consideration of desperate measures. It's not a standard approach in someone with multiple small bone metastases, but it's certainly not off the table.
I mean, I think what we've illustrated, if I try and wrap this all up together, is, medicine is an art. And part of that art is, not being afraid to question yourself, question the results, as data comes in and it looks different from what you expected, go back to the basics. It's also about communication. And I think this has been a wonderful experience for me, partly because Bill is such a gifted communicator, and, interacting with Ron has always been a pleasure. So for me, this was a wonderful case, even though it's a mystery and a conundrum of just everybody working together for the greater good. Ron, do you want to wrap it up with any last thoughts, and Bill too?
I just wanted to go back to one thing that I think is something I've been observing more, and now there's actually data reported by some major radiation centers. But patients who have radiation therapy to brain lesions, some of the worst cases of tumor necrosis that I've ever seen has occurred in patients who have subsequently received immunotherapy.
Okay.
And this is something that's being reported more commonly now.
That's interesting. So that may be what was going on here. I mean, certainly I've seen it without immunotherapy, but that's certainly consistent with your theory. Any advice for other patients?
Yes, I do have advice for other patients, and I read this on the Facebook, which sounds trite, but really is very useful. I hear patients saying that their doctors are not open to doing other tests. They're not open to considering other things. They're not open to hearing another opinion. And I just flat out tell them, you need a new doctor. And it's been, if some doctor tells you that you don't need another opinion, or I'm not going to consider that, or I mean, you just need to find a doctor that is open to other opinions. That, I mean, look, here we're talking to the top people, and then neither one of them claim that they know exactly what to do in any particular situation, and they're open to hearing other opinions. So to another patient, I would just say, have a good rapport with your doctor, and a doctor that isn't opposed to hearing another doctor's opinion. I mean, this is complicated stuff. And so, yeah, everybody should be open-minded. And if you have a doctor who's not open-minded, you need to change. And I see that pretty frequently. It kind of amazes me. And people are afraid, patients are afraid to question their doctor. And so they just kind of go, and you kind of just say, well, I'm sorry, you don't want another opinion, I'm gonna go get one.
I mean, I think that's a very important point. The other thing that I try and do, and I'm sure Ron gives as many second opinions as I do, is we have to remember that the guy who is there on the ground is the person who is ultimately responsible for the care of their patient. And if I'm a second opinion, I'm an opinion, and it's not my job to police the other guy. It's not my job to look over their shoulder every time, but it is, I think, my job to collaborate and inform and act as a sounding block. And as Ron said, we don't have to agree on everything, but at the end of the day, it's the person who's treating the patient who actually is the one responsible. So they can't say, well, I just did it because this other guy told me to do it. So I think part of a remote second opinion is knowing the boundaries, and that applies as much to the people requesting them as it is the people giving them.
Yeah, the patient's their own best advocate. Really, the more time you put into it, and hopefully you have somebody there with you to help you think through all these things, and you just talk to other people experiencing the same thing. It gives you a lot of comfort. And, it's obviously a difficult time. And for me, anyway, the type of person I am, the more information I have, the more comfortable I feel with the decisions I'm making versus just blindly going down a path.
I think, Bill, you really illustrate what an empowered patient acts like. I think this story, even if it's not wrapped up with a nice bow and here's the end, I think it's illustrative of what groupthink can do in the best way. And so with that, I'd just like to wrap this up, and I'd like to thank Dr. Natale, I'd like to thank Mayor Bill Brand, and I'd like to thank you for watching. So thank you, and here's to solving all the mysteries.